Welcome. Today we're going to do something a little different. We're going to put ourselves in the shoes of a brand new first-year psychiatry resident. We're going to walk through one of the most common and most critical decisions you have to make: how to treat major depression. We'll be using an evidence-based algorithm as our guide, specifically for depression that doesn't have mania or psychosis.
So, you're on call, you have a new patient, and you're faced with this question. You look at the list of medications, and there are dozens of them. How in the world do you choose? Is it just a gut feeling? Do you just pick one and hope for the best? Well, the good news is there's a map you can follow. It can feel overwhelming at first, but having a structured approach like this brings a ton of clarity. And this number, 11%, this is exactly why we need a map. A massive study looked at 250 million patient records and found that for about 1 in every 9 patients, the path their treatment took was completely unique to them. Now, you might think that's personalized medicine, but what it really points to is a huge amount of variation in care. It means that depending on which doctor you see, you might get a totally different plan.
And that's where algorithms come in. They're all about moving away from just guesswork or personal habit and toward a guided, evidence-based pathway. It's about making sure every single patient gets the best possible shot at getting better, right from the very beginning. I absolutely love this quote because it hits the nail on the head. Of course, experience is valuable, but without a guide, without checking our habits against the evidence, we risk just getting really good at doing the same thing over and over, even if it's not the best thing. An algorithm is what keeps us grounded in the science.
So what's the payoff for following a system like this? Well, the benefits are pretty clear. This isn't about turning medicine into a robot's job. It's about getting better results for our patients. They get into remission faster. We reduce that random variation in care that we just talked about. And in the end, it's actually more cost-effective for the whole system.
Okay, so let's jump into the algorithm itself. As a new doctor, this is your very first decision point, and it's a huge one. It immediately takes one very specific group of patients and puts them on a completely separate track from everyone else. So the first question you've got to ask is this: is my patient hospitalized with severe depression that has what we call melancholic features? And melancholia isn't just being really sad, it's a specific biological subtype. We're talking a near total loss of pleasure, feeling worse in the morning, waking up way too early, and often some serious physical slowing or agitation. If the answer is yes, you go down a very different road. And this next step really drives home the algorithm's focus on safety first. For these incredibly sick patients who are at urgent risk, maybe they're actively suicidal or catatonic, the #1 recommendation is electroconvulsive therapy, or ACT. Why? Because it works faster and more reliably than any medication we have, with some studies showing remission rates around 75%. And if ECT isn't an option for some reason, IV ketamine can be a great, fast-acting bridge to get them stable. Okay, so that's the most severe, urgent group. But honestly, the vast majority of your patients won't fit that description. So what about them? What's the starting point when it's time to choose that very first medication? Now, for patients who are hospitalized with that same severe melancholia but aren't at immediate acute risk, the algorithm points us toward more heavy-duty options. We're talking about dual-action agents like venlafaxine and mirtazapine, which hit both serotonin and norepinephrine. Or even the older tricyclic antidepressants, TCAs. Yeah, they have more side effects, but for this specific kind of severe depression, their effectiveness is really well proven. And now for everybody else, which is most of the people you'll see in clinic. The algorithm starts with the medications that have the absolute best balance of working well and being easy to tolerate, sertraline and escitalopram. But, crucially, it lists bupropion right there alongside them. And that's because bupropion works on dopamine and norepinephrine, not serotonin. For patients who are really worried about sexual side effects, which can affect up to 80% of people on SSRIs, this is a fantastic first-line choice.
Okay, so you've made your first choice, you've given it a good trial, but your patient isn't getting better. This isn't some rare failure, you know? The data shows this happens about half the time. So what's your next move?
This is probably one of the most common questions you'll ask yourself. Do I scrap the first medication and start a totally new one? Or do I keep it and add something else to boost its effect? You know, the big studies don't really show a clear winner between switching and augmenting. And that means the decision becomes a conversation. It's a true moment of shared decision-making with your patient. So how do you guide that conversation? Well, you think about it like this. Did the patient get any benefit from the first drug? Even a little bit. If so, maybe augmenting makes sense. You're building on something that's already working. But if they got zero response, or if the side effects were just awful, then switching is probably the way to go. All right,
Let's say you and the patient decide to switch. What are your go-to moves? Well, the simplest is just to try another one of those first-line drugs. Maybe move from sertraline to bupropion. Or you could switch to a different class entirely, like one of those dual-action agents, to hit different brain chemicals. And for patients who want to avoid more meds, you could consider something like rTMS, which is a non-invasive brain stimulation therapy.
Now, what if you decide to augment instead? You've got some great options here too. You can add something with a really low side effect profile like L-methylfolate. You could add another antidepressant that works differently like bupropion. Or you can go to some of the most evidence-based strategies we have, adding a small dose of a second-generation antipsychotic like Riprazolve or one of the old-school classics like lithium or thyroid hormone.
So, let's imagine your patient has now been through 2 different adequate medication trials, and they're still not better. This is a really tough place to be, for you and for them. And at this point, we're officially entering the territory of treatment-resistant depression. Once a patient meets this definition, the statistical chances of the next medication working drop quite a bit. So this is a huge signal to just pause, stop, and rethink everything. Is the diagnosis 100% correct? Are there other medical issues? Are there major life stressors that we haven't addressed? You have to go back to square one.
Now, for these really tough cases, the patient's specific symptoms become even more important. If they have what we call atypical features, which means their mood can still brighten up with good things, and they have increased sleep or appetite, then an older class of drugs called MAOIs becomes a fantastic option. They're tricky to use with dietary restrictions and all that, but for this subtype, they can be incredibly effective.
And this brings us to the final and maybe most important layer of the whole algorithm. What if the depression isn't getting better because it's not actually the main problem? What if it's a symptom of something else entirely? This is where your whole strategy can just completely pivot. If a patient has depression but also chronic pain, a TCA might be your best bet because it treats both. If they have underlying OCD, you might need to push the SSRI dose way higher than you normally would for depression alone. And my favorite example, if your patient has untreated ADHD, sometimes treating that directly with a stimulant can make the depressive symptoms just melt away. It wasn't the primary problem to begin with.
So, what does this all mean? Is treating depression just about following a flowchart? Not at all. What this algorithm gives us is an incredibly powerful, evidence-based roadmap. It shows that there's a real logic to this process. It doesn't get rid of the art of medicine, it gives that art a strong foundation to stand on. It ensures that our clinical judgment and, most importantly, our patients' preferences are always part of a smart, well-structured plan.